Today I will discuss history taking for part 3 MRCOG together with the structure of consultation, which is important as it ensures patient safety, efficiency, and better patient engagement. Marking in part 3 MRCOG will be according to the 5 domains. Each domain will be marked for all stations, separate from other domains, and finally in the safety it could be pass, borderline, or fail. Within each domain, you will have many points in the mark, could be 5, 6, or less, and each point will be pass or asterisked, and if missed, you will take borderline, and if it is fail, they will write if the candidate didn't meet this criteria, candidate should be assessed as fail in this domain. So fail in one of the criteria mean fail in the whole domain, and if you had asterisk in one of the criteria, you will have borderline in the domain, and if 2 borderlines, you will be assessed as a fail in this domain. So believe or no, 1 point could make you fail in one of the domains, but it is very easy to be known because it depends upon the module and the criteria of the module given. In some domains, you may find one of them take more mark than the remaining domains. Like in breaking bad news, communication here will take more mark in the communication, which means you may find 3 or 4 failure points. If you skipped one, you may fail the next. That's because communication is a very big issue in bereavement stations and breaking bad news stations. And also in the emergency situation, another example, or high-risk obstetric patients, you may find patient safety is a key domain here, and they take more marks, and more failure points would be there. Sometimes they put 3 failure points, that's all in the same domain. Now, what do I mean by clinical and lay examiners in MRCOG Part 3? Clinical examiner will be a doctor, senior obstetrician, or gynecologist, will be assessing the domains according to given mark sheet, and he will strictly follow them. Lay examiner will be non-medical professional evaluating communication, information gathering, and safety, and usually the assessment will be for 3 domains, and usually they don't assess the applied knowledge domain. We have general marking sheet for the clinical examiner, and he will have, in addition, another mark sheet specific for the case. In general safety domain, will include the most important points, which are pros and cons of management in balanced way, understand the importance of written information, limits of your clinical abilities, and referrals as indicated, and to understand the clinical governance issue. In the communication with the patient, to make appropriate introduction with your full name and role, and to establish rapport and put patient at ease, encouraging dialogue with the patient, avoidance of and explanation of technical terms, empathy, active listening, ability to discuss the topic in a sensitive way and appropriate manner, acknowledge and address patient's concern, respond to patient cues, give space to allow decision making by the patient. Give space to allow decision making will be emphasized more with the lay examiner, and I will explain in details. In information gathering, will be the relevant clinical history with no major omissions, signposts and the guides for relevant and directed consultation, and understand the patient's likely concerns, check and ensure interpretation and understanding at appropriate intervals, appreciate the need to consider all available evidence and sources. The applied knowledge domain, interpret and explain clinical findings accurately, justifies further investigations and management options, synthesize a comprehensive and well-organized management plan based on interpretation of the clinical information. And for the lay examiner, mark sheet of lay examiner will include safety domain, which is information giving, which means that you can give the information which allow the patient to be able to make decision, and you have to present the risks in a balanced way, no forceful, scary, or hierarchical language. Support the patient to make informed decisions and reflect these when formulating a plan. Show recognition that the patient is the ultimate decision maker, signpost the patient to further relevant sources of information, and give time for the patient to consider the option. So closure of the station will play important role to pass the safety domain of the lay examiner, because at the end you have you will tell her that you are at the end it will be your decision. You can take your time to make decision, and you can wait until you meet the consultant or go through the written information, and I will give you at the end it will be your decision, and I will give you a follow-up appointment and give me your final decision. Giving her a relevant source of information means that you have to give the true information reference, like the RCOG leaflets or NICE, or in communication with the patient, use audible language, explain medical jargons, check patient's understanding at intervals. So you will tell her, am I clear? Are you following me? Give a clear introduction to their name and explanation of their role. So you should tell, I am Hala Shauki, I'm the doctor in the clinic or in the ER today. I'm here to discuss with you this issue. You have to establish rapport and put the patient at ease, encouraging dialogue, and demonstrate active listening skills, both nonverbal eye contact, body language, and verbal paraphrasing to show understanding, verbal affirmations. You can say in between, when she is explaining to you, telling you a story, I see, okay, and then what happened, and extra to establish your communication. Use language that conveys empathy, compassion, and respect for the patient. All these communication issue will be explained in details. Then the information gathering. Explain clearly the reason for the consultation and what is meant by history taking. So you have to, in your purpose should be clear purpose. And usually we take the purpose copy paste from the given scenario. What is meant by history taking, that you will take her permission in the agenda and tell her that I need to ask you a few questions first to know more about your condition before I give you the management plan. Establish and address the patient's concerns. Every patient will have 4 or 5 concerns. If you didn't address them during the consultation, she will ask you them one by one, and you have to acknowledge by telling her, I appreciate your concern, or I acknowledge your concern before you address. Encourage the patient to ask questions and follow up as appropriate. So in between, you will tell her, am I clear? Are you following me? Do you have any question? Use combination of closed questions, yes or no answers. And open questions, how and why, to give the patient a chance to describe their concerns and preferences. So all these issues in the domains are explained in details in the my lecture before about the domains. Listen to the lecture before to be able to understand all the specific points here. Framework for consultation. The following steps provide a structure for a medical interview, which will help you to build a relationship with the woman. 1. Initiate the session. 2. Gather the information. 3. Physical examination. 4. Explanation and planning, and then close the station. Introduce yourself. First impression is the last impression. Introducing yourself properly is very important to build up a good impression on examiner, as well as to build a rapport with the role player. Outside the cubicle in the 2 minutes, you had to get into the mood of the station and understand the theme. Enter the room when the bell rings, and non-verbal body language, including eye contact and smile, and take your seat. Meanwhile, your aim is getting the sitting right, appropriate positioning in the chair, and try to be at the same level as the role player. Keep targets of introduction in your mind. So you will greet the patient and say hello, and tell your identity and role. So I am doctor, and you can decide how you will introduce yourself. Explain your role. Usually we say one of the doctors. You have to know where are you. Usually in the questions they will give you whether you are in the clinic, in the ward, or in the ER. So I am one of the doctors in the ER according to the scenario. So in summary, you will say, hello, I am doctor. I am one of the doctors in the gynae clinic today. And may I confirm your full name and age, please? And how can I call you? Or you can say, can I call you Amy, or whatever the name given in the scenario. Then the purpose. Confirm the purpose of the meeting. Usually it is taken from the given scenario. You will say, I understand from GB letter that you are here because, or I understand that you want to discuss about this procedure, or I understand you have this problem. Is that right? And then ask this question. Anything else would you like to add? Because this will help you to identify hidden agendas. Because some stations, the patient will not have the same complaint given in the scenario. They will have some hidden agendas or some hidden concerns. If there is any concern or expectation from the consultation today, then set your agenda. Usually we say, is it okay if I asked you a few questions to know more about your condition? We talk about the hidden agenda. You have to be mindful, observe the patient, and pick the verbal and non-verbal cues which could be given by the patient. Which point that she had something hidden and there is underlying issue you need to explore. We have what we call ideas, concerns, and expectations. This is the key to pass the station. So the ideas is what the patient think is happening to her. The concern is the patient. What is the patient worried about? For example, the postmenopausal bleeding, worried about it could be a cancer. Expectations. What the patient hope will happen in her treatment. Like if the patient have heavy menstrual bleeding, she may expect to be offered hysterectomy or medical treatment only. How we apply ICE or ideas, concerns, and expectations in the exam. You can use open-ended and probing questions. Ideas you can ask, what do you think might be the cause for your problem? The concern, is there anything particular that is worrying you about this condition? Expectations, what were you hoping we could do for you today? Benefits of using the ICE, it helps to build rapport and trust with the patient, ensure you address the patient's real worries, and help tailor your explanation and the management plan to the patient's need. Structure of history, we have current complaint, obstetric history, which include the past pregnancies, whether full-term pregnancies, miscarriages, or terminations, current pregnancy and future pregnancy wish, gynecological history, including menstrual history, contraception, smear and sexual history, past medical, surgical, medication, allergies, social history, including work, smoking, drug, alcohol, and exercise, family history, BMI, and at the end, ask her if she has anything else she would like to add. Closed-ended questions are used to elicit specific details of the presenting complaint, and they close down the discussion and make it very clear that the consultation is based on the doctor's agenda rather than the patient's expectations. It is characterized by, it could be answered by yes or no. For example, do you have pain? She will say yes or no. Usually begin by when, which, did you, like how many pads do you use per day, or do you pass clots? The best approach is to use blend of mainly open question and some closed questions, and to avoid repeating the questions. Common pitfalls, wasting time by asking irrelevant questions. For example, asking the patient presenting with postmenopausal bleeding how old they were when they started their period, the menarche. Asking mainly closed questions, repeating questions and not listening to the answers, ignoring cues from the actor. You need to concentrate on the history of the presenting complaint and related history. When you listen or find out the patient complaint in the GB letter or from the patient's own complaint, you have to make differential diagnosis. Then ask questions that make one diagnosis more or less likely or to rule out the diagnosis in or out. Constipation and irritable bowel are common conditions in the teenagers, so the history should cover them in the non-gynecological questions. If the girl hasn't been sexually active before, this will logically rule out the possibility of STIs and mean no need to take swabs from vagina or cervix and no need to ask about dyspareunia. So this will show that the candidate has listened to the answers to the questions and that they are not doubting the truthfulness of those replies. The actor's instructions. The role player instructions will not be briefed to mislead the candidate by giving incorrect information or lying. They are given a specific script and have been carefully briefed to ensure that they understand their symptoms and the background so the candidate can be confident in the truthfulness of the replies to their questions. The actor is instructed to give the key clinical information to the candidate in response to open questions. And then the competent candidate um, should therefore ask open questions and use the answers to guide them as to what is likely to be the examiner's mark sheet. You should be able to gather information both about clinical problems and wider issues relating to that patient in order to ensure a holistic, patient-centered approach to information gathering. Signposting. Signposting in communication means guiding a listener through a conversation by clearly indicating what will be discussed next. And this will help to build the structure of the consultation and ensures clarity. Before you start to explain, for example, the next step, which is the investigation given in the scenario, you can say now, what we will do, I will discuss with you the results of investigations. Signposting also help to explain the patient's structure of consultation. If the patient was very worried about cancer and she mentioned, I am worried about cancer, then you can tell her, I appreciate that you are worried that you might have ovarian cancer, but I would really help. It would really help me if I could just ask you a few questions before I explain the results of your scan. This indicates to the patient and examiners that you are aware of her concerns and you are going to address them with a patient centered approach once you've obtained some key and focused information in which to frame your response to her concerns. Avoid repeating questions at all costs, as it suggests you are not listening to the answers. If you need to repeat a question because you haven't understood the actor, explain this to them by saying something like, I'm sorry, I didn't understand that. Could you explain what you mean, please? Information gathering does not mean information gathering isn't limited to just history taking. Structured discussion could include information gathering in the form of explaining which investigations are required. You have to explain what the relevant investigations are and ensuring resources are not wasted in over investigation and that the patients are not exposed to unnecessary risks linked with invasive testing. Again, information gathering is not limited to history taking. So, in a case of root cause analysis, the task could include writing a task involving reviewing a clinical incident, making a plan of the approach to gather information in order to undertake root cause analysis. And this information gathering could be from the patient file, from the doctors who attended the incident. You should understand how to review documentation. Again, information gathering isn't limited to just history taking, because in root cause analysis, your information gathering will be involving writing a task involving reviewing a clinical incident and making a plan of the approach to gather information in order to undertake root cause analysis. You can gather this information from the staff, from the patient notes, and from the guidelines. You should understand how to review documentation and be able to describe a plan for information gathering to contribute to root cause analysis. Then you should be able to use the information collected in root cause analysis to debrief or explain events to the patient to explain events to a patient or their family in an open and honest way without undermining the colleagues. Again, information gathering is not limited to history taking because the task may include information gathering in the form of interpreting the results of investigations or operations, like in the debrief stations, post-hysterectomy or oophorectomy. You will have long details in the operation note, and this interpretation of the notes will be counted in the information gathering, like failure points. CTG traces given in the stations, like in the teaching station, you will have a CTG trace. You need to do the right interpretation, and for sure it will be a failure point in the applied knowledge domain. Present complaint. And of course, it will be a failure point in the information gathering domain if you didn't interpret in the right way. May also be in the knowledge domain. Also in the labor ward, if you have a patient in labor and they bring the CTG to help you decision for operative vaginal delivery, the right interpretation of the given trace will be in the like failure point in more than one domain, not only information gathering. Discuss history taking in details. The best approach is to fix a certain set of questions for every item in the history taking in order to be used and to it all the time, and to be able to pick up the target history with every patient. First point in the history taking, the present complaint. So this is the best way to begin your history and ask details about them sensitively, including onset, duration, progress, management, relevant symptoms, related risk factors for particular symptoms. This demonstrates to the examiner your understanding of potential diagnosis. Important negative answers are also important as positive answers. Establish patient emotions with these symptoms, and you should start empathy from here. If the pain is, for example, is a current complaint, you have to analyze the pain, offer analgesics, and ask her if she had anything for the pain relief right now. And this is the empathy point here. Set certain set of questions for obstetric history, and here is the general history, and then later you can apply according to your patient. Usually we ask about the baby movement, if applicable, and in the start by current pregnancy. If the patient is pre-pregnancy, you can ask about if she started folic acid, had the rubella test. She see if the patient had any comorbidities, and then cover the control and assess and the control of that condition, like diabetes. And if the patient came while she's after pregnancy, you can ask, is this your first pregnancy? Was it planned? If unplanned, ask her how did she react. So if she's happy with the pregnancy, or she can consider termination if allowed, or if applicable, how her partner reacts, and any local problems, whether financial or housing problems, which could affect her because of the pregnancy. Did you start folic acid? How far in your pregnancy? Or when was your pregnancy test after your period? How was the result of blood tests and scans so far? If near delivery, you can ask about the plan for the delivery and the plans for the future pregnancy. In the previous pregnancy, have you ever been pregnant? Any problems in the past pregnancies or deliveries? Any problems happened after delivery? How many children you have? If the patient had miscarriage, you have to show him empathy and tell her, how did you feel about the miscarriage? How did you cope? I'm sorry, I have to talk about that, but that information might be of help. So in the miscarriages, usually after you show empathy, you have to cover the gestational age at the miscarriage, and what was the management. Was it medical or surgical or conservative? And any complications happened after the miscarriage, better to establish her blood group if she had surgical termination, because you have to ask her if she received the NTD or no. If the patient mentioned that she has termination, first ask her if she want to talk about the termination. Was it personal reason? And how did she feel and cope the time? Sometimes the role player will be show some cues that she's hesitant to discuss about the previous termination. So she may want to hide from her current partner that she had ever had any termination in her life. Now you have to reassure her about the confidentiality. In the gynae history, we have to cover in the current complaint duration, severity, which makes it worse, what make it worse, what make it better, and ask her what do you think could be the problem, because in gynae complaint like pain, pelvic pain, for example, you will have many reasons, many differential diagnoses, and we have to establish her ideas in terms of her thinking what could be the problem. She may be afraid it could be cancer or any other concern. And we can consider it like also a hidden agenda because sometimes a patient wants to discuss something else other than what is mentioned in the GB letter. And ask her what has been done so far, any problem, any other problem. You have to start by making a differential diagnosis for the given gynecological problem, and remaining questions will be around making this differential diagnosis to suggest that one of these diagnoses is most likely the most likely diagnosis. And you need to start your history chronologically. Then ask about associated symptom to make your differential diagnosis. Ask about what water works or the wee. And if she has any positive problem in the urine, like incontinence or dysuria, you have to complete the full uro history. And any problem with the bowel opening, any vaginal discharge, if it is there, you will ask about color, odor, amount, any pain in the lower tummy or burning urine. So instead of the abdomen, we say tummy. And any discharge, how you will ask? You will ask by telling her, any discharge from down below. Can you tell me about the discharge? Is it itchy? Is it with a smell? Is it with a smell you don't like? Of course, not all these questions will be asked for every patient. It could be asked when it is applicable. Move on after the current complaint and associated symptom to the menstrual history. Please can open question by asking her, please tell me about your period. MRCOG, the age of the first period should be asked if the patient, if it is applicable. If it is accompanied by pain, the amount of bleeding, the regularity of the period, and the last menstrual period. So we can ask, can you tell me more about your period? When was your last period? Is it heavy? Any clothes, floats? Or you can ask her about the tampons, how many tampons she can change, or if she's using many tampons per day. And is it painful? If positive pain, you have to ask about the details of the pain. Any bleeding in between periods? Is it regular? How regular? And by how regular, you are asking about the regularity, whether it come every 28, 35, or a regular period. In perimenopause and postmenopause, we can add menopausal symptoms, hot flushes, body aches, and if she tried using hormone replacement therapy or no. The next in gynae history is the smear. First, look at the age, because if the patient below 25, this means she didn't start her cervical screening program. But you need to ask the question about the human papillomavirus vaccine. And in applicable stations, it could be borderline point in the history taking. And contraception. So ask her if she had any current method of contraception, or if she used in the past any methods of contraception, and if she had developed any side effects from any previous contraceptive method. So here is the sexual history in details, some personal questions, and are you in a regular relationship? and any problem with the sex, like pain or bleeding after sex, and are you currently in contraception, and what is the method, any previous methods, and if she had any complication from the previous methods, and if she had any STIs, and how she protect her against STIs during the sex. Number of the partners is important, and don't hesitate when you ask about the number of the partner. How you will ask, you will tell her, are you in a regular relationship? Or you can ask, are you in a long-term relationship? And do you have any other relationship? And my advice here, never be hesitant or embarrassed when you ask sexual history related questions, because this will embarrass the patient and it will be taken against you and make you fail communication with the patient. Social history will include occupation. Ask, what do you do for living? Job make difference in some stations. Example, solicitors could be related to time factor. Air hosters usually prefer the dark. Secretary could be relevant to chronic pelvic pain, PMS, because the patient has to deal with customers. Her PMS may affect her communication with their customers. Sex worker could be related to STIs, HIV, and depression, and the housewife could be related to the depression. And smoking. Do you smoke? Do you drink alcohol? Any recreational drugs? And not necessarily every patient should be asked about recreational drugs. Domestic circumstances. Who do you live with? How things go at home, and support. Do you have enough support at home? Our aim from these questions to rule out domestic violence, and in chronic diseases like chronic kidney disease, chronic heart disease, or other chronic diseases, support question will be like borderline point. Summary. In structured discussion, you may be asked to present the summary to the examiner using the SBAR, and usually it will be failure point in communication with the colleague. In simulated patient tasks, summary is an important point in the lay examiner mark sheet in the safety domain. It should include next step, for example, to arrange for an ultrasound and the necessary referrals. Like I will refer you to the psychiatrist to give relevant patient information leaflets. In some stations, you have to name them, particularly if it is belonging to RCOG patient information leaflet. So you will tell her, I will give you the RCOG patient information leaflet about ectopic or recurrent miscarriage. You have to give website for support groups if it is applicable, and sometimes you need to name the support group. Ask if she has any question at the end and if everything is clear to her. If you have options, you need to tell her in the closure that she can take her time. If it is not emergency situation, she can take her time to decide, and don't press her in making the decision right now. But she can talk to her friends, to partner, and read the relevant information, or talk to the consultant, and then you can arrange for her an appointment to give you her opinion, and also you will give her the contact numbers. Thank you so much for watching. I hope it was useful for everyone, and wait for me. I will make introduction for each module separate, inshallah.